Next up we have actually Dr. Pat Garrity is going to be presenting evaluating the use of glass, Wi-Fi, and MAC scores as predictors of limb salvage success in patients receiving free tissue transfer for chronic lower extremity wounds.
Super. Thank you very much. Unfortunately, Hayden Schott, who did this work, he's a biomed engineering student at WashU who works with John Felder, one of our plastic surgery colleagues in limb salvage, wasn't able to make it, so I am his poor substitute. Let me trigger forward here. Sorry, this floor is interesting. So when we look at peripheral vascular disease, we know that's a complicating factor for lower limb reconstruction. The schematic on the right, derived from the Global Vascular Guidelines paper, shows how the presence of peripheral vascular disease in its various distributions affects outcomes, be it from diabetes, smoking, age, and other factors. There has been some research in the past looking specifically at the effects of underlying PVD on free tissue transfer for limb salvage, although it's been fairly limited to date. So the question we wanted to ask was, does the objective severity of PVD, as characterized by various grading systems, give us the ability to properly select patients and predict outcomes when we are engaging in free tissue transfer for limb salvage? Here are two clinical scenarios that highlight the problem. On the left, patient one, or on your left as well, we have a gangrenous, more extensive foot wound that has a severe disease seen on the angiogram. On the right, we have a more discrete wound with a better-looking tibial angiogram. Both of these patients underwent free tissue transfer. On the right, patient one fully healed in and is ambulatory. Patient two was complicated by widespread breakdown, underwent multiple subsequent procedures, debridements, ended up with major amputation. So looking at these two patients, it wouldn't be immediately evident at the outset which one of these would have gone on to failure and which one would have been the successful wound healing. So our questions were, how could we use staging tools to assess the severity of patients, of the disease in these patients, and better predict their outcomes, both with local flap salvage, amputation, as well as 90-day and 1-year mortality. 3 validated scoring systems exist. The GLASS system that was brought out in the Global Vascular Guidelines has both femoropopliteal and infrapopliteal grading components, as well as a pedal scoring system. The Wi-Fi component I think everyone is familiar with. And finally, the MAC, the medial arterial calcification grade, and I'll dig into that a little bit as we go forward. So again, GLASS, we have a cumulative series of scores that adds up for the total, both the femoropopliteal grade, infrapopliteal, and more importantly here, the pedal GLASS grading, P0 with no significant disease, at least one intact pedal vessel and arch, P2 with a missing arch, P3 with no vessels crossing, I'm sorry, P1 with no arch, and P2 with no vessels crossing into the foot. Wi-Fi grading we're familiar with, looking at both wound, ischemia, and infection severity. Virtually all these patients were a Wi-Fi grade 4. Finally, the medial arterial calcification grading system, for those of you who are not familiar, a really good paper from UCSF this year looking at the applicability of that to characterize outcomes. It actually works independently of Wi-Fi. And it looks at the AP and lateral angiogram or X-ray views and has a scoring system of calcified segments of the dorsalis pedis, plantar arteries, metatarsal, and hallux and non-hallux vessels. These can be grouped, if you see at the bottom right there, 0 to 1 scores as group 0, group 1, and group 2 as we ascend in the severity of the pedal MAC score. So in the study design, we looked retrospectively at all patients who had received free tissue transfer for limb salvage by a single surgeon, Dr. Felder at our institution, and we characterized them both by GLASS and Wi-Fi and the pedal MAC score, and then looked at their outcomes and analyzed them retrospectively. The endpoints, flap failure, 90-day amputation rates, and mortality and major morbidities at 90 days and 1 year. Here are the demographics. Again, just a single-arm group, so not particularly insightful. Preponderance of males, fairly high prevalence of diabetes, less smokers, kind of reflective of the more recent composite picture of this population. What we found in this busy slide here is that the pedal GLASS and the medial arterial calcification scores were the ones that were significantly associated with the negative outcomes. Fairly low numbers of overall P2 patients there, but if we look ascending from P0 to P1, it was strongly significant in terms of predicting 90-day mortality, 1-year mortality, and both 90-day amputations and, prior to that, 30-day flap failure. Same true of the escalating pedal max scores. Furthermore, if we combine these in 2x2 format, we found the greatest sensitivity for poor outcomes was if we had both an elevated max score and an elevated P1 score. The total P2 were very low numbers and couldn't be used to derive a score here. So in conclusion, if we look at these 3 validated systems, how can they contribute to our predictive value or predictive grading of patients who are approaching a potential free flap for limb salvage? First of all, if we look at the glass systems, the femoropopliteal, infrapopliteal segments are not helpful, but the pedal scoring is helpful in contributing to this potential outcome score. Wi-Fi, interestingly, is not useful in terms of predicting these patients who will fail, but the pedal max score is useful. What did we miss about this patient too? When looking retrospectively at this information, we see that the patient lacked a pedal arch and had a high pedal max score. So with our retrospective knowledge, we would have classified that patient as a much higher risk for failure following free tissue transfer. So in conclusion, severe PVD is a risk, as we well know, for major morbidity, amputation, and mortality in all patients, but that applies also to free tissue transfer attempts for limb salvage. High pedal glass scores and high max scores provide clinically relevant information regarding the increased occurrence of poor outcomes in these patients. We certainly need more patients to make definitive statements here, but we found that this was a very interesting early look at this kind of potential way to bracket patients and predict outcomes when we're attempting kind of somewhat heroic limb salvage. Thank you. I'd be happy to take questions. Questions at the end. Grill away.
Great talk. Thank you for sharing this data. So does this mean, when there is a failed attempt at the free tissue transfer, are these candidates will be good for deep venous arterialization, for other modes of revascularization effort? This is a great scoring system for us to sort of learn and think about how we can approach the problem here. Thank you.
Just a quick answer is we started doing these just a couple months ago, have now done 5 DVAs that were predated this series. So I think it absolutely is a next step in a lot of these patients, and to my mind, this kind of really ties in tightly in terms of overall outcomes when we look at what Dr. Ferraresi and others have published for what he calls the bad and sad distribution, meaning these calcified smaller vessel disease on the foot, that I think that is a absolute target population for DVA salvage.
Hey, Pat, John Matsumura from Wisconsin. A great paper, a tremendous experience with 57 patients like that. And I think the key is sometimes finding a plastic surgeon who will work with us like that. And,
yeah, he trained with Chris Addinger at Georgetown.
Yeah.
There are very few.
And I think it's really informative what you've shown, that the distal disease is important. My question is about why Wi-Fi was not important. And one of the things we learned when I was in Chicago is you have to do really aggressive debridement, multiple trips to the OR, so that you don't have underlying infection when you lay the flap on. And I'm just curious what your protocol is there in WashU about how you clean up the wound surgically before you do this.
Yes, so absolutely. It's not a one and done. So Felder will generally do serial debridements back to healthy tissue. These patients will undergo, I think 2 of these patients underwent bypass grafting for inflow for the flap. So we'll occasionally do that, and we're actually starting to look at the use of a DVA conduit as inflow now as well for flaps, because we're enthusiastic about flaps here. They actually work fairly well, and as you mentioned, it's kind of a very limited patient subset, but when you see some of the wins, it's truly impressive. Because a lot of these times, if you're left with a long-term open wound granulating because you can't have free tissue transfer, it's a portal for infection, and then 6 weeks out you think you're winning and suddenly you have a necrotizing infection, whereas getting an immediate full tissue coverage for these I think is unbeatable.
Thank you.
Sorry.
Chris Goltz from Flint, Michigan. Just a question about your hospital protocol as far as when these patients are candidates for free flaps. Are they successfully revascularized, quote unquote, and is that why the glass non-pedal score is important and the pedal one is deemed as important? So
all patients would undergo an attempt at revascularization, yes. In general, the glass score was calculated post-revascularization. So if we undertook angioplasty, This was a post-angioplasty characterization of where their flow stood. And it can be a little fearsome when you're looking at these. That's why having a pedicle flap allows you to essentially extend down from ankle level basically to cover, you know, what we would normally think of as something where you need a patent arch to have perfusion. You're kind of bringing that perfusion with you. But interestingly, the calcific nature of the disease is still a predictor for the outcomes. Even though you're kind of moving that pedicle site back up off the foot, the impact is still there.
Thank you.
We need to move on, Pat.
Oh, I'm really sorry.
Yeah, sorry. Thank you.